We get started, Ari is working on getting logged on right now. But good morning, everyone. Thank you for joining us today. This is the 5th media briefing that we're holding as part of Brown County Public Health's collaboration with our local healthcare system partners. We have Advocate Aurora Health and Aurora Bay Medical Center, Bellin Health Systems, Prevea Health, HSHS St. Vincent and St. Mary's hospitals, and we're also working collaboratively with Oneida Nation Public Health and the De Pere Health Department. So before we start today, I just want to say on behalf of all of us that are who are involved in these briefings, we'd like to say thank you to our media partners for joining us, and to other public health departments and healthcare organizations for joining us and helping to share the stories that we're bringing to you through these Faces of COVID briefings. It's important information, and we hope it's making a difference in our communities. Today, we're going to talk with 4 frontline COVID fighters, physicians who are experiencing and dealing with this recent surge firsthand. Before we go to our speakers, I will provide you with a brief overview of the current status of COVID-19 in Brown County. Today, we are sitting at 19,602 confirmed COVID-19 cases. That's an increase of 219 over yesterday. We're sitting at 102 deaths. We have 17,000 individuals who are out of isolation. That's an increase of 288 over yesterday. As always, you can find an updated dashboard at www.stayhealthybc.com. You can also check the DHS website for current information. As you can clearly see from the information on your screen, we continue to have rapidly increasing cases of COVID-19 in our community. The impacts of that are far-reaching, and the physicians with us today are among the many healthcare workers and essential workers who are dealing with this firsthand. Joining us today, we have Dr. Raul Mendoza, who is a pulmonologist at Aurora Bay Medical Center. Dr. Mendoza does a weekly COVID-19 report on his medical Facebook page and videos to educate the Hispanic community about the pandemic. We have Dr. Paul Casey, an emergency medicine physician with Bellin Health, who is also part of their COVID-19 incident command team. He's been a vocal advocate and educator for following the science to prevent the spread of COVID-19. We also have Dr. Manar Al-Shahuri. He's a Prevea Health pulmonologist and critical care physician. He's been caring for patients hospitalized with COVID-19 at HSHS St. Vincent Hospital and HSHS St. Mary's Hospital Medical Center since the start of the pandemic. Lastly, we have Dr. James Heise, who is the Chief Medical Officer at Door County Medical Center and a member of their incident command team. Dr. Heise has played an integral role in informing and educating the Door County community on the latest COVID-19 developments. Thank you, gentlemen, for joining us today. To get our conversation started, let's talk about the current surge that's going on. This fall, it's seemingly much different than what we saw in the spring. How does it look from your perspective, and what are you seeing? We're going to start with Dr. Mendoza, and then we'll go to Dr. Casey. Dr. Heise, I might slide you in before Dr. Al-Shahuri to make sure that he gets logged on. But let's start with Dr. Mendoza. Again, the question is, it's different now than it was in the spring. How does it look from your perspective, and what are you seeing? Dr. Mendoza?
Hello, and thank you everyone for doing this. First of all, congratulations to all the community for coming together. And a special thanks to all the healthcare workers, parents, and communities, because we know that the duress that we are facing, and I know very much how fatigued we are by this pandemic. I am fatigued, and I understand that how people can be fatigued. However, the reality is that we are seeing an increase in the COVID-19 cases, and in our system, definitely, we are experiencing a second surge. Not only there is an increase in the positive of percentage positive COVID, but also new cases are on the rise, and also we see a steady, ongoing, and increase in hospital admissions. and increase and steady ICU admissions, which eventually may translate into deaths based on the statistics. I want to remind to the community that even though we are not at capacity, we have some flexibility. Definitely, we're on the second surge, and the actions that we take today may impact the community spread down the road. And I think that is the most important message. We are on the second surge, and if we take action today by social distance, wear masks, avoiding crowds, avoiding gatherings, we will be on a better place, because I can start seeing, as we were going to discuss, some interventions that may affect this pandemic for the better, but we cannot quit before the finish line.
Thank you, Dr. Mendoza. Dr. Casey?
Thank you, Claire. Nathaniel, if you could bring up that graph I provided, I think it's an excellent representation of what we're all seeing in this community. So this graph represents Bellin's inpatient admissions dating back through April. And I'm sure all the other healthcare systems in our bell-shaped curve back in April. Our first admission at Bellin was on March 31st, and then we had a 2-month surge. Our maximum hospital capacity of COVID patients was 12.5% of our hospital capacity. And by the 1st of June, you can see we were down to 1 inpatient with COVID. And then the summer progressed. Unlike some other places in the country, we did not really have a second wave, but we definitely have a second wave now. This really started on right after Labor Day, about a week after Labor Day. You can see that chart really starts to rise. And we're currently in this sustained plateau of a steady influx of COVID patients. The peak you see there represents about 25% of our total hospital capacity at Bellin. And what this means is that hospitals typically are all very busy. We're at 80. On top of that, 25% of hospital capacity filled with COVID patients really puts a strain on all our healthcare systems. On a daily basis, we're teetering on the brink of being full and not having capacity to take care of every patient that needs care.
Thank you, Dr. Casey. I believe I see Dr. Al-Shahari was able to join us today. Good morning, doctor.
Good morning. Hi. Sorry, I had patient care issues. Can you hear me okay?
Yes, I can hear you and I can see you. Thank you so much for taking time out of your busy day to join us.
Oh, no,
right now, Dr. Al-Shahari, we're talking about how this fall COVID-19 seems vastly different than what we saw in the spring. And we're just wondering, from your perspective, what are you seeing and why is it so different this fall than it was in the spring?
This definitely has a very different feel. It's a lot more intense. In a way, the first wave, I've kind of said this before, what I thought the first wave now in retrospect, although I'm not entirely sure this is actually a second wave. I think this is a continuation. I think this is just a ramp up of the initial one. And what the first one seems almost like a dress rehearsal for what we're dealing with right now. At the beginning, we certainly have seen a lot of patients come through, a lot of sick folks, but we did not come to the point that we were at capacity or frankly near overwhelmed, and we did not see the sustained intensity we're seeing right now. What we're seeing right now is almost, if you look at the data, we're almost the caseload and the positivity is almost vertical. And that I believe the latest number that we had 42% positivity rate in the community, which is the very definition of a runaway pandemic. What we're seeing right now as well is the community spread. Before, we could almost always tell how the patients were exposed. Now it's I think rare for a patient to even can tell us, which tells me they're getting it from their immediate context, typically family. So that's kind of where we're at. This definitely has a very different feel for it.
Thank you. And Dr. Heiss, what about you? What are you seeing?
Yeah, I agree with what everyone else has said. This definitely has a different feel. One of the things in Door County that we're seeing is really fully 85% of our positive cases since the beginning of this pandemic have taken place since September 1st. And what we're seeing now, different than before, is many, many more of those positives are translating into ED visits and subsequently into hospitalizations. And we're a critical access hospital with 25 licensed beds, and which with capacity for more. But as of yesterday, we had about 45% of our inpatients were COVID-19 patients. So this is definitely, I think I agree with Minar from the perspective of, I think that this is sort of a continuation of the first wave. But it definitely has a different feel. And unfortunately, I think all of us are bracing for even more to come.
How are your hospitals handling the increase in patients? Dr. Casey, how is your hospital handling the increase in patients?
So I'm sure we're all doing the same thing. We've had to cohort COVID patients to keep them all in the same area. I have to give kudos to our facilities team, who's done an outstanding job in creating negative pressure rooms, which are critical to care for COVID patients. So we've turned an entire medical ward into a COVID unit with 26 beds, and we have overflow capacity on our orthopedic and neuro unit. And then separate to that, we have a separate portion of the ICU that's been dedicated to COVID patients that turned into negative pressure rooms. So we're doing what we call coexisting with COVID, meaning we want to continue all normal operations in addition to taking care of this influx of COVID patients.
Dr. Al-Shahari, what about you? What are you seeing at your hospital, and how are you handling the increase in patients?
Okay, sorry, I was unmuting myself. Dr. Heiss, I love the Millennium Falcon, by the way. Very cool. So we're definitely seeing a lot. We're becoming innovative. I think what we've learned over the past few months is to have better triage patients. We've definitely learned. We had a much better sense right now of which patients are more likely to deteriorate, et cetera. So we've kind of changed our operations accordingly. Everybody's stepping up. Everybody's working really, really hard. It's been a lot of physical, emotional strain. But so far we're handling. We're doing well. But we are at near capacity, to tell you the truth, and it's wearing down on us without a doubt.
Dr. Heiss, what about you in Door County? How are you handling the increase in patients?
Well, in our case, capacity has a lot to do with staff, and I shouldn't say in our case, we're all in the same boat. We're fortunate in that our physical plant, we have physical ability to move people in different areas and to increase our capacity, which we're really lucky to have. But of course, staffing is the big piece, and so we're doing okay right now. But we're meeting, twice a day to sort of sort out, what can we do to make sure that we have the capacity we need? Because at this point, when we have patients come to the ER, we really don't have any choice but to take care of them in the hospital should they need hospitalization. So we have to figure out how to make that work.
And Dr. Mendoza, how about you? How is your hospital handling the increase in patients?
That's for me, right? We're lucky. We have a large system that gives us a little bit of flexibility. I want to put a little bit of the positive spin, if we can make something positive. Unlike the first wave or the surge that we experienced in March and April, at least we have now access to fast testing, and we have plenty of testing available to test a lot of patients from admission to surgeries and procedures and whatnot. And then we also have a good inventory of protective equipment for our healthcare workers, and so at least that is a relief. In between also, as Dr. Al-Shahari pointed very well, it was a dress rehearsal, and the summer gave us time to adjust a little bit to do with engineering the areas where our COVID patients are existing right now, So the second floor in our institution is where most of them are there, and then we have negative pressure rooms, and so right now we are getting creative with the staffing, trying to meet the needs for the community. So I want to remind everyone that if you have COVID symptoms, most of them that can be taken care at home, and with close communication with your providers. But if you have any symptom, any respiratory problem, short of breath, or you think that your oxygen saturation is going down, or your fever is not coming down, we will make sure that you receive the care that you need in all hospitals. And the same, don't be afraid. We're trying to make sure that the operations, the daily operations, your surgeries are happening. So we have learned, as they pointed before, to coexist with this. And I want just to remind everyone that how important this year is for you to receive the influenza vaccine, because we don't want to be dealing with two viruses in the community at the same time.
Thank you, Dr. Mendoza. That's actually a great segue into our next round of questions. So there's a lot of misinformation out there that's being shared on social media and other avenues, and we'd like the panel of doctors to address some of the more concerning pieces of misinformation, which could be very harmful to our community during this time. We're going to approach this sort of like a quick round robin, and I'm going to direct a question to each of the doctors. Dr. Al-Shahari, let's start with you. Does the flu vaccine make you more susceptible to COVID-19?
Okay, here we go. Okay, sorry, I keep unmuting myself. No, there's for that, zero, big whopping zero evidence for that. And I don't know how that started, or it just makes absolutely no sense. I mean, so just period.
Sure,
and I would love to talk about this later. You know, I hope that we'll get a chance to address the bigger issue here, which is the slew of misinformation and what's circulating. And I hope we'll get to a point, because I think that's a super important issue. I think honestly, that has been as big of a challenge as the disease itself, and this has been one of the major issues in us getting this under control. And I have a different take on all of this. What you think, but I think that's something I hope this panel will discuss, and I'm interested in other people's thoughts on this issue.
Dr. Heiss, I'll go to you next. Is COVID-19 really a threat to public health?
Oh, absolutely. I mean, that's is that a question? I mean, yes, it absolutely is. I think, aside from the clear, what we've all talked about, patients who are sick enough to require hospitalization, emergency room care, clearly we've had deaths related to the mortality rate isn't that high, but that doesn't mean that there's not that there's not morbidity, meaning problems that come as a result of COVID. And let's not forget that as our hospitals are becoming more and more taxed with these COVID patients, we also are seeing normal healthcare problems. People come in and they have heart attacks, or they're having a stroke. And when we're inundated with so much other things, the level of care may not be up to what we would like it to be as a result of there being COVID. So is it a public health risk? Without question.
Dr. Mendoza, you sort of touched on this a little bit before, but cold and flu season is upon us. And there's a myth out there that getting a flu shot and eating healthy and doing all the right things will help you avoid getting COVID-19. And if you're a healthy person, it doesn't matter if you get COVID-19 or not. Can you touch on that a little bit?
Yes, thank you. I encourage everyone to remain as healthy as possible, to exercise, to eat healthy, and to have a sensible diet. But unfortunately, of course, getting the flu shot, but unfortunately, despite everything, in the wards, we see all kinds of patients, not only the elderly patient with multiple comorbidities or the obese patient. We see otherwise healthy people, young people, admitted to the hospital in serious trouble. I've seen patients young patients with no comorbidities die of this condition. And more important, we know there was a study in the Annals of Internal Medicine showing how people who are admitted or have COVID, important COVID, they were having symptoms and disability even 60 days after. So yes, I encourage everyone to remain healthy, because the healthier you are, the stronger you are, the better your fighting chances. But that is not a guarantee that you will not acquire the virus, and that is not a guarantee that you will do fine. So I encourage not only healthy diet and exercise, but also get your flu vaccine and also practice all the public health guidelines: mask wearing, social distance, and avoiding gatherings, avoiding crowds.
Thank you, Dr. Mendoza. And Dr. Casey, some people claim, to Dr. Mendoza's point, some people claim that masks and social distancing don't make a difference. Do they?
Absolutely. Thank you for that question, Claire. This is actually my personal pet peeve. For 9 months now, I've been preaching wear a mask. We're in the middle of a once-in-a-century global pandemic that is caused by a virus that's transmitted by breathing on somebody else. So it's just common sense. If you wear a mask and the other person near you wears a mask, the chance of catching that virus is very low. There have been a number of studies scientifically that use lasers and droplets that show that these droplets are not transmitted through two masks. It's very simple. And a huge testament to that fact that those of us in the medical community for 9 months have been exposed on a day-to-day basis within a foot of people with COVID, and none of us have gotten infected. That just shows that masks work. And you know, it's unfortunate that this issue has been very politicized, and that it's a political statement to wear a mask or not. That shouldn't be an issue. This is a public health issue. We have to all wear masks until these vaccines become available if we're going to prevent a dramatic rise in deaths.
Thank you, Dr. Casey. I know how frustrating it is to keep hearing these rumors, especially when all of you and your staff are working so hard to save lives. We're just also wondering, I'll open this up to everyone. Anyone can answer in any particular order, how you all are keeping focused during this time and what keeps you going.
Well, I'm answering. We're all shy, right? So I have a wonderful group of colleagues, friends, and family. I think that's what is keeping me anchored, grounded. I communicate with the rest of my extended family via Zoom and other camera devices. So our weekly talk with all my siblings and my mom, and it's just good, keeps me grounded. My family is wonderful, and I have a good colleagues here as well. I try to exercise at least 5 times a week, as much as my time allows it, and I usually read or watch some type of videos that are more uplifting and inspirational, and try to avoid negative things. But that's what keeps me grounded: just family, friends, exercise, and just looking for positive things.
Yeah, I guess I would say, not to be sickening, but I mean, in many ways, just professionally, I mean, this is our moment. I mean, so it's sort of, as Dr. Casey said, this is a once in our lifetime global pandemic, and so this is our time to shine. Now, that doesn't mean that we're not all exhausted and we're not sick to death of COVID. When people say to me, I'm really tired of hearing about COVID, I always say, you're not half as tired of hearing about COVID as I am. But I think to Dr. Mendoza's point, I think family is so important in these times. Just taking some time. And one of the things that I'm not particularly good at, I'll be honest, but I do it now, is just gratitude. The whole sense of this is, we're blessed to be in this situation to try and take care of patients, and also just remembering what we've got when we get home. I go home to a wonderful wife and a son, and I've got nothing to complain about.
As an emergency physician, I can say this is what we do. our usual world is controlled chaos. So the COVID pandemic is just an extension of what I do for a living. In a prior life, I was a military physician. I was deployed to Desert Storm and Somalia, and we had a mission. And I view this as nothing other than another mission. I've been given a mission to tackle COVID. We've been all been given this mission, what we can to help stem the tide of this pandemic.
Thank you for your service, Paul.
Thank you.
So last week we heard that a vaccine is close at hand. We're also hearing that there's a new drug that's been approved for treating COVID-19. Is there anything that you can share with us about it? This can go to any doctor.
Well, I go again.
Claire, I'm sorry, what was your question again about the vaccine?
We're hearing, we're hearing that a vaccine is close at hand, and we also heard that a new drug has been approved for treating COVID-19. Just any thoughts about those two things? But what happens when the vaccine comes, and if there is a drug that's been approved, what happens next?
Can I answer the previous question? I'll open that. I'm sorry, I was kind of distracted here a little bit.
Of course.
But what keeps us going and such, for me, it's actually simple. It's an extension of being a dad. I live in this community, my children live in this community. I just want this to be a safe world for them. And that's what I want. And that's what motivates me, and that's what gets me going, is to make this safe for them, for my children, for my friends, and that's what really motivates me. And that has always been from the very beginning. And frankly, with all that's been going on as of late, and the denialism and the distractions, it's even more important to me that all those folks who have been affected by COVID, whether ones that died, ones who are still suffering from it, you'll hear things about like long COVID, and their families, that their suffering, their losses need to be validated. They need to be put to the forefront and understand that this is real. It's something that is affecting all of us. And these are my two motivations. I'll let the other docs talk about the vaccines and such. I can happy to chime in about that as well, but I don't want to hog the discussion.
So this week, we've actually had excellent news that we have 2 vaccines that are going to be available very soon. They're new types of vaccines. They're called messenger RNA vaccines. They make the body produce antibodies to the spike protein. And so we're very excited that we're going to have vaccines available very soon. The unfortunate thing is, though, that we're not going to be able to vaccinate the entire population probably till the middle of next year. So the important thing about the vaccines coming out is that we have to remain diligent until we can all get vaccinated. So we can't let our guard down just because we now have vaccines that we're going to have available. The other important thing about the vaccines is we all need to take them. Even though these are new vaccines and they're going to be released on what's called emergency use authorization, they're very effective. I don't know that we've ever had vaccines that are 95% effective by both the Pfizer and Moderna vaccines. Typically, on a good year, the influenza vaccine may be 50% effective. So I'm very excited that we now have a more effective tool that's going to be in our toolbox in the coming months.
I think to add on to that too, what's going to be important for people to realize is that even when the vaccine starts, it's going to be prioritized. The government and the state and the Department of Health Services is working on ways to prioritize who gets it first and how do we go down that line. So as Dr. Casey said, it's going to be well into middle or third quarter of next year. So we're going to need to continue those hygienic measures, the wearing of the masks, social distancing, washing the hands, avoiding crowded spaces, things like that. That's going to continue. That's not going away any day soon. Also, it's going to be a 2-part vaccine. So it will take, I think one is 21 days apart, one is 28 days apart, but I'm not certain of that. And so again, it's not going to be an overnight, get a shot and you're done in a day. It's going to take a little bit of time. But it is coming, and I think most of us in this business are very excited about it.
We welcome all these beautiful and promissory scientific news, and like everything is an evolving situation that is very promising. And right now in our system, we have a command center that is looking at all the available data when the FDA, the emergency approvals will happen, and how the distribution will follow. And what every system probably is doing is the logistics of potential distribution, because the vaccines will require special handling with different temperatures, and then we need to make sure that, because this is a two-step vaccine, that no vaccine is wasted. If you go for your first shot, eventually you need to go for your second shot. Otherwise, it's a waste of vaccine for someone who could otherwise have used it. In regards to the monoclonal antibodies, that's again a very promising. It's based on 450 patient data. It looks like it may reduce potentially the hospital admission rate. But again, the challenge will be on the infusion centers. How do you staff them? Where do you put patients that are known to be infected with COVID and to receive a 1 hour infusion? So we are, the systems, and my system, Advocate Aurora, are working really hard on trying to speed up that process, and eventually we'll get there. But as everyone has mentioned, it will take several months before that is a reality. And not only that, it will take several months before that shows as a real impact in the current outbreak. So we need to remain with what we know that has worked. I know that, but this is just the finish line. And this good news are around the corner, but we need to keep doing that until that becomes a reality.
Can I chime in with a couple of thoughts? So you, Claire, I think you've asked also about the antibody, the Eli Lilly lepilimumab, and that's something that in a pandemic, it's always been convalescent plasma and monoclonal antibodies and finally a vaccine, and we've kind of at incredible speed. I don't know if people appreciate the achievement. I mean, the scientific prowess of this country to actually get us a vaccine that efficacious in such an incredibly short period of time. That is, I mean, this is civilization saving, and I'm not overstating that. That is incredible. But Dr. Casey made a great point here, but people have to take it. The issue that I really want to stress here is that there's been a failure to connect and communicate with the community. We have failed to engage with them. We've talked at them. We have lectured to them. And there have been competing narratives all along, be it mask, no mask, vaccine, no vaccine, etc. There's just the discussion ended up being, who's yelling at whom, and this is complete disengagement. And I find that a problem because, frankly, now we come through, we have this very effective vaccines. And now is the issue of well, let's talk to people. Let's see, are you going to show up and take it? And and we can get into the epidemiology and how many people need to have it to get vaccinated so that we have herd immunity. And by the way, herd immunity is only applicable in the presence of vaccine. So let's not be clear on that. Herd immunity is not, let's let it run wild. That's not the way it works. So we need to engage with the community. We need to explain that. Honestly, what I would have really have liked, and unfortunately because of the politicization of this whole issue, what I really would have liked is at a community level, be it a local college or local university, or even at level of high school, where we have taught the community, kids at school, college students, is that let's talk about some fundamental epidemiological concepts here. Let's talk about what is an RT, what is an R naught, what is a dispersion factor, and once we explain these things, you'll understand these discrepancies between what people are saying and what we're saying and what they're justifying their actions. Say, well, masks don't make a difference. Well, I've been to such and such function and nothing really happened. We've been getting together and there's been no issues at all. And so these kind of concepts, are hardcore epidemiological source of information that we can explain to the community. So this way, once you engage with them, I mean, people out there are fairly intelligent folks. You know, they try to make sense of things at their level of their education, at the level of expertise. And not all of us are physicians, not all of us are epidemiologists, you know. So they try to make sense of it within the context of what they understand. And frankly, because of this vacuum on our end, you know, us being, be it the media, be it the medical community, be it the colleges, to kind of go out there and engage with the community and explain to them, look, this is important. You know, explain to them why is it that we want them to not to get together, and kind of really go over that and explain to them concepts such as the dispersion factor and the differences between that, and why is it that
Thank you, Dr. Al-Shahari. We lost you just a little bit at the end there, but I'll circle back to you after I ask my final question. So to the group, as we close out this session, advice for the upcoming holidays. We're right on the brink of a time of year when lots of people want to be gathering with friends and loved ones. So final thoughts on the upcoming holidays and what you're seeing and experiencing.
So with our current community spread rate of greater than 30%, if you get together with 10 family members who don't live in your own household, the chance of someone in that gathering becoming infected is fairly high. So that's the unfortunate reality of what we're facing right now. So you have to take that in. Hold in-person gatherings for Thanksgiving. What that means in practical terms is really, do you want to be responsible for killing your grandmother? I mean, that sounds harsh to say that, but that's what I see on a daily basis. I take care of patients in the ED who come in, they're elderly, they live alone with their spouse, so they don't go anywhere. And I ask them, where do you think you caught this virus? And they say, we don't know, we didn't go anywhere. Well, who visits? My grandchildren bring my groceries. So that means the grandchildren brought the groceries to the grandparents. So if you get together in a room with 10 family members in a small space that's not well ventilated, when the community spread rate is greater than 30%, the chance of someone catching it and not doing well is very high. I don't say that to be mean. I say that as someone who on a daily basis takes care of people who did not need to get infected. People over 70 who get coronavirus need to be admitted, and 30% of those who get admitted will die. So that's the harsh reality of what we're facing.
You know, and I put it, I got this from a colleague of mine who had said, don't let Thanksgiving dinner become the Last Supper. I mean, and that really is, that kind of puts it down to brass tacks. And, you know, I know we all want to be able to get together with our families, but look, this is 1 year. And if we can just avoid, you know, maybe get together by virtual means, that sort of thing, I think that is a way better situation. I know all of us, all the physicians on the screen right now, I think we all unfortunately anticipate a couple of weeks after Thanksgiving, we're going to see a spike. And I would really love to be wrong on that. But I think, you know, I think we just need to do what's right.
In the Midwest, one of the main ways of transmission have been the small group gatherings, other than socializing at bars. So we need to remind that, and the holidays are upon us, and that's probably what is going to increase the transmissibility. So I will just echo what they have been saying, and I want for everyone to be safe. And on top of that, here in the Upper Midwest, we have that compounded with the hunting camp, and and people get together for a yearly ritual, which is beautiful, but not in the middle of a pandemic. So if you go there and then you get together with your friends, and then you go to your Thanksgiving dinner, that potential will contribute to spread the disease. So think twice and scale down, cancel plans if possible. Everyone will be grateful. Your community will be grateful.
Dr. Al-Shahari, I think we have you back. We're just talking about any thoughts you would like to share about the upcoming holidays, as we are on holiday season.
Yeah, thank you. I'm sorry. I wasn't sure how much of what I said earlier, but what I was just, my message honestly is that I would like for us somehow to engage with the community. I don't want to be talking at them. I don't want to be lectured to them. I want to understand why we make these recommendations. Why is it that we say, please wear a mask, please don't congregate in a bar? We've learned a lot about this virus. We know if you're in an enclosed space, the chances of transmission are much higher. We also know, and I don't know if that came out earlier when I said it, that when you realize 10% of all infected individuals with COVID-19 are responsible for 80% of the spread. So you can imagine that these so-called super spreader events and such, this is unique to those SARS viruses. Influenza, for instance, does not behave that way. The dispersion factor for influenza is almost 1, like the original pandemic from 1918. MERS, SARS 1 and 2, they have a dispersion factor of 0.2, 0.3. So these sort of gatherings are instrumental in the spread of this illness. And I would like for people to understand that. And why is it that we make these recommendations? We're not trying to shut businesses down. We're not trying to ruin things, Thanksgiving for folks. We're not trying to do any of these things on purpose. We are making these recommendations based on the science that we know. So I would just say, look, and again, this thought, yes, don't make this the last supper. We've had our fair share of weddings that ended up in funerals. We've had our fair share of funerals that end up in more funerals. So, just think about it. I would love for folks to be more curious. I would love to have resources for them to engage and understand why we make these recommendations.
Thank you, Dr. Al-Shahari. And thank you, all of you, for joining us today. I know you have full plates and busy schedules, and your insights are so helpful, and we know and hope that they'll make a difference. Before we go to Q&A, because of Thanksgiving next week, we will not be hosting a media briefing. We are looking at resuming these in early December, and we'll keep you posted about the specific dates. We can now open it up to questions. As always, if you could please state your name, the media outlet you are reporting from, and who your question is directed to.
Hey, Claire, Rob Sussman, WTAQ. My question's for the doctors. You had mentioned that you don't want people gathering during the holidays. I think that the truth of the matter is a lot of people are going to anyway. Is there anything that you would tell people who are insistent on gathering, anything that they could possibly do to reduce risk of transmission?
Be creative. We realize people are going to get together for Thanksgiving, and you just need to be creative. If you can find a way to open windows, perhaps eat in the garage with the door open, wear masks for part of the time, anything you can creatively do to limit being in close proximity in an enclosed space without ventilation will go a long way to preventing illness.
The best holiday will be only with your close group and your immediate family that you have been quarantining together. But I echo what Dr. Casey said, and the only thing that I will add is if you can avoid traveling, that will be one thing that may decrease. Mobility is associated to increasing the transmission. So if you can avoid, of course, avoid going to two houses, going to one house and then I go to my in-laws. That will be just an invitation for the spread of the disease and another outbreak. And So if you can also quarantine yourself and then, just don't go out until then. Again, this is not giving anyone's permission. The ideal situation would be no. But if you must and then you have no other choice, then do it in a smart way. And as Dr. Al-Shahari had said, I mean, there's science out there. So there are recommendations out there about how to minimize. There's never zero risk, for how to minimize the risk to have safe holidays.
We had a couple questions come through on the chat. So this is from Christina to the doctors. Can someone talk about how common the complications from COVID-19 are and how they affect the quality of life long term?
There was a study that came out several months ago that the study looked at patients who'd been hospitalized with COVID. I believe it was 60 days after discharge, and 40% of those patients had lingering effects of COVID. This is totally different than common respiratory illnesses like bacterial pneumonia or influenza. Typically, people get influenza, they recover, they have no long-term sequelae. COVID-19 pneumonia, on the other hand, causes lung damage. People have lingering effects. Even patients who are asymptomatic, the recent study showed that there's cardiac involvement, they get inflammation of the heart muscle, and the long-term implications of that are not yet really known. So this is a totally different disease that we've never seen before, and it has long-term consequences.
And two, think of it this way. I mean, from a perspective of diseases that we know about, we're 10 months into this. And so when we talk about long-term effects, there have been reports of those, as Dr. Casey eloquently mentioned, but we don't know. I mean, when we talk about long-term, 10 months is not long-term. So I think we're already seeing signs that there will be some long-term consequences to this. And I think we have to really pay attention to that because we don't know what's to come yet.
And I would say this. I totally agree with that. It's very worrying that we are seeing already a non-resolution, if you will. You're probably going to hear more and more about the so-called long COVID, where patients basically report not going back to normal. They still have. There's actually been some data to show some of the patients who have had some neurocognitive decline. There's certainly evidence for that. There's evidence for persistent shortness of breath with resultant lung disease. But ultimately, the long-term side effects of that we'll have to wait and see. Just to remind you of something as monumental as 9/11, when we had that, and the lung diseases that resulted from that took us years to fully understand the scope of what happened. And that was as monumental as an event as that was. And it was studied very well. It took us a number of years to really get a good scope of the effects of that. This is something that affecting millions. So, and that has to be taken into consideration. This is not even to say the psychological impact this has had. The loss of the social distancing and the physical distancing and the effect it's had on our children, et cetera, et cetera. So this is something that's going to be with us for a long time to come.
Just want to point out this recent article in the Annals of Internal Medicine in 450 survivors of COVID, kind of 450, and 60 days, 2 months after they were discharged from the hospital, and 1/3 of them had remaining symptoms. 1 in 5 still had shortness of breath. 1 in 10 were unable to walk yet. 1/4 of them with shortness of breath climbing stairs. 8% of them are still on oxygen, and 1/3 of them not able to return to their normal activities. Out of those 450, 195, this is younger population, were employed at the time of when the infection started, but 78 of them could not go back to their jobs, and many of them, they lost their job. So there are many long-term consequences, not only health, but economic consequences of this pandemic. There is a recent article published in HHS for sports medicine guidelines, because even in young people with mild symptoms, there is a lot of asymptomatic cardiac issues. About 15% of them, they can have by ultrasound of the heart, they can have evidence of cardiac inflammation. We don't know the long-term consequences, but they are advising just a slow reintroduction to exercise on these type of patients. So we're learning a lot. We don't know all the evidence, but there are potential long-term consequences, and we will know more. And that's another reason to be cautious and protect yourself, even if you are young, even if you are otherwise healthy.
We had another question come through in the chat. Given that everything we've talked about today regarding indoor gatherings, is it unwise for many high schools throughout the state to move ahead with high school winter sports?
I will need to hear the question again.
Yeah, I'm sorry, Dr. Mendoza. Just in the interest of everything that we've talked about today, this individual is wondering about high school winter sports and if that's a smart idea to move forward with winter sports for youth at this point.
Well, there was a recent morbidity and mortality weekly report from the CDC, where hockey camp in Florida, there was an outbreak of the COVID-19 virus. It was in young people, young adults, but clearly it is in indoors. It is spreads quite easily. Any contact sports. I don't know about snowboarding. I don't know about skiing. I know I've been asking, and then they are modifying the lifts, and then they're trying to keep social distance. Everyone required to wear a mask, and the lifts probably they're going to be spread, and not 4 or 5 people traveling at the same time. But we don't know. This is our first winter with this virus, and we will know. So a lot of caution.
Can I? Yeah, go ahead. I'm sorry. Go ahead.
No, I'll make the unpopular statement and say, I guess what I want to understand is how is it that many schools in the Green Bay area are not in session? They're doing virtual schools, but yet we're going to do basketball and wrestling in gyms. So I guess I don't see that the two they don't logically follow in my mind. So if we're okay to do wrestling and basketball in gyms, then shouldn't the kids be back in the classroom?
So I totally agree. And so here's the thing. We know that this virus has ideal spread in an area that is enclosed, close contact, and a loud place. We've seen that. So when you're telling me there's going to be a sport that is going to be indoors, there's going to be close physical contact where those kids or the participants are going to be shouting, yelling, and breathing heavily, that is the recipe for the spread. It's that simple. We know this. It is what it is. So, and that's again my point. Again, engaging with the community and talking to them about it. Explain. Look, these are sort of things. Not everything is created equal, and these sort of activities run that risk. So, with all due respect, I don't think it's safe, especially if you look at the CDC guidelines for opening up schools. There are certain prerequisites that they have, and one of them is that, what is your percentage positivity in the community? When we talk about 42%, everything is out the window. I mean, you cannot possibly do it safely, and it's just not doable. So and again, I don't want to be lecturing and talking at people. I want to engage with them, and we need to kind of somehow have a venue where we can discuss these concepts. When we talk about the so-called RT, this fundamental reproductive number that you hear epidemiologists talk about over and over and over again, one of the determinants of that value is the social connectivity. And so you can manipulate all these numbers, but if you have that piece where people are coming in close contact together in such an area, then that's the problem. We've seen this at the very beginning of the wave, where we've seen in certain types of businesses that the workers were in very close proximity, and we know what happened. So we're almost replicating the exact scenario now in a high school gym where these young athletes going to be engaging in close physical contact that involves heavy breathing and talking and yelling, etc. We know about the cases in the choirs of the churches. We know about all these things. So
so take time for one more question. Another question came through in the chat about staffing in the healthcare systems. Do you think that you are in need of more healthcare workers, and are nurses being asked to work more shifts? What is the overall mood of the workplaces as the pandemic continues?
So staffing is an issue. We may have physical beds, but we have to have the staffing to take care of it. At Bellin, where I work, we fluctuate between 150 and 200 staff members out on quarantine due to either having COVID or being exposed to COVID. So that's a significant portion of our workforce. So as a result, we've had to call in agency nurses, so-called traveling nurses. We've never had to do that in the 15 years I've been at Bellin. We've had to do that, and these agencies are taking advantage of that. They're charging $200 an hour for an ICU nurse, which is a lot of money. So the staffing is a huge issue for us.
And by the way, one of the things I'll point out, and Paul's exactly right, at least just speaking for Door County Medical Center, unlike what you hear in the press, we are not paid more for COVID patients. Doctors are not paid any additional money for taking care of a COVID patient. Far from it. As Dr. Casey mentioned, traveling nurses is a very, very expensive commodity. You have people working overtime, things like that. That does not bode well for the bottom line of hospitals, especially if elective cases need to be canceled or postponed. So these are all, they're really, so as far as Door County is concerned with the question about staffing, we're doing okay. Nurses are working multiple shifts. There's a lot of overtime happening. People are exhausted. People are tired. But we all know we have a job to do for our community. So that's what we're going to do.
Okay, at Aurora Daycare Medical Center, being part of a system, we have not only the flexibility of having great workers that they are tired, and then we have asked a lot out of them, but also we have the flexibility of people that work in other service areas to be able to pick up some shifts here and there, and so that has helped us a little bit, but again, I think every single system has been strained, and it's been 9 months now, and without a break and asking overtime to a lot of people. I think everyone is suffering the same, but we still have some capacity to accommodate the demands of the community.
In the interest of the doctor's time, I'm just going to allow for one more question. We had one more question come through in the chat, and actually, Dr. Heiss, I'm going to direct this one to you, just based on where you're located. So Tim is wondering how close we are to a breaking point with patients, whether they have COVID or not, having to travel far distances to get treatment because of hospital capacity issues.
I wouldn't use the word breaking point. I think, I guess my goal is always, I don't want to engender fear in the community, because we'll take care of patients as they come into our facility. But as far as at what point will people have to travel far distances, that's already happening. Unfortunately, that's just the reality of it. When Green Bay facilities are full, we've had to transfer patients to the Fox Valley, to Theta Care. We've had to transfer patients all as far away as Gunderson Lutheran in La Crosse. So it's happening already. Thankfully, those are only a few cases. That's not the norm by any means. But that is the big concern. So when people talk about, well, I don't think COVID is a big deal, it's like, well, whether you think COVID's a big deal, it is absolutely affecting our ability to efficiently and effectively manage patients.
All right. Thank you to the doctors for your time today. Again, we really appreciate it. For everyone who celebrates Thanksgiving, we hope everyone has a safe and healthy Thanksgiving next week, and we will talk to you in early December.
Thanks, Claire. You guys stay safe. Thank you.
Thank you, Dr. Al-Shahari.
Bye now.